Good afternoon, and welcome to this week's ISAG public meeting. The theme this week is public health action and COVID-19. What does it mean, and where can it take us? The focus of our discussion will be very much on the work of the regional public health departments, with particular reference to the issues and challenges in relation to contact tracing. But of course, there is a lot more to the public health response to COVID-19 than contact tracing, and we will address in this discussion the urgent need for further development and in investment in our public health infrastructure at both local and national level to respond to the current pandemic, and to ensure that we are adequately prepared for the next pandemic. We have two excellent speakers this afternoon. Dr. Douglas Hamilton, who's a public health specialist and medical officer of health with the Midlands HSE, and Professor Anthony Staines from Dublin City University. To kick off, as usual, we will have a brief situation update from James Merrick. Thank you, James.
Thank you very much, Ivan. I said, the agree with Carja. So the scale and lay in you is the kind of synopsis before we go into the chart is that things have been very stable in Northern Ireland compared to the last few weeks that we've been showing. It's kind of continue as is, and in the Republic, there was good news in the sense that the rise in cases we've seen the last couple of weeks has leveled off. We still have this issue that over half the cases are in young people, and so we can get into the charts now. Please, Ben, when you're ready. Thank you. I just want to acknowledge Paul Dempsey and team for the work behind the scenes in collecting this data and organising it. And I'd also like to explicitly acknowledge Olive last week for her help with the chart on the outbreak data. So if we could, next slide, please, Ben. So just starting with Northern Ireland, and this is a linear scale, daily average cases per 100,000, same chart we've shown the last few weeks, and if different line colours, different age groups, but maybe we'll just focus on the black line, which is just the population-wide average, and it's this continuing trend of at a pretty low level of a slow decline, and we're actually going to trying out something new this week and showing some Northern Ireland on with the Republic of Ireland data as we break out the age group. So we can go to the next slide, please, Ben, and we'll talk about the North a little bit more there too. So just before that, breaking out the age groups, this is a chart we've shown most weeks, breaking out population Republic by healthcare workers and non-healthcare workers. With the healthcare workers, the blue line. I just mentioned there that I just mentioned there as regards healthcare workers. We've shown this chart as a sign of the benefits of vaccination, how it drove levels lower than the general population, but how it also takes time. But it's probably surprising that it's not even lower for healthcare workers. So it's something we'll probably want to dig into. Maybe some healthcare workers, maybe not all healthcare workers have been vaccinated yet. Maybe there's something else going on. But in terms of the general population, the kind of yellow-orange line here, we've seen this sort of leveling off in the past week, and we'll just go into that a little bit more as we look at the age groups. So if we go to the next chart, please, Ben. So there's a lot happening here on this chart with the older age groups, but and we're intermingling the Republic and Northern Ireland. But I just, without getting into details of the particular lines, I just make the point is that it's pretty good. It's at a low level and continuing to go down. And I'll just draw attention to the green line, and that is 85 plus year age group in the Republic. And we've had 5 days in a row of 0 cases in that group. So, that's really great news and kind of the benefits of the vaccination program. Next slide, please, Ben. So this is kind of upper middle age groups, and so there's a challenge here that Northern Ireland cases are not broken out. Northern Ireland cases are not broken out by the exact same age group, so there's a little mix here. But I'll just make the point, the difference between the blue and orange line here is that the orange line is Republic, 55 to 64, the blue line is 45 to 54. So there's this increasing divergence between those lines, and I suppose that's down to increased vaccination in the older of these two age groups. And in the north, that it's 40 plus here, 40 to 59. That's lower, and I suppose that's just a sign of the vaccination program in the north is ahead by a few weeks into lower age groups. If we go to the next slide, please, Ben. This is kind of younger age groups, but still adults, and so this blue and orange are 25 to 44 in the Republic. It's at a higher level in the older age groups, and significantly higher than Northern Ireland. And there's a little uptick there at the end. It could be noise. As we saw, there was an increase when schools opened. It's leveled off a little bit. So again, we'll keep an eye on it. And the next slide, please, Ben. And these are the cases in children. And so there was large outbreaks in well publicized, some of them in a number of towns and schools. Social gatherings as well mixed in with that, and they seem to have been contained. And there has been further outbreaks in the past week, and we've seen the daily case numbers in this age group. And there was also a May break for some schools. This kind of the last 2 weeks there was increasing cases in these children and young adults. That was a concern. It's leveled off this week. That's in terms of the situation of that's where we are. There's many different factors. Maybe easier to have windows open with the better weather and do things outside in schools. There's many different things going on, but that's encouraging that the kind of increase we've seen has broken, and I suppose we'll be monitoring it going forward. And if we go to the next slide, please, Ben. The point that this week that's interesting is that we had in the Republic we had a record week of vaccinations. I think we broke the 250,000 7-day rolling average yesterday, which it's encouraging. This is just a snapshot, May 11th, of the case breakdown by age in the Republic, and we see like half the cases are in 34 and younger, approximately, even more than half actually, and the median age has been dropping to kind of from early 30s down to lower 20s, and of course this is the age group which is generally furthest away from vaccination. So that's part of the challenge going forward, and I'm sure we'll be talking about today. If we go to the next slide, please, Ben. Yeah, I just wanted to make a kind of part of what's happened in the news the last week. Just to make a quick point, in certain people have been pointing this out, that there was increased emphasis on airborne transmission of the virus in WHO and CDC in the US in the past week. And looking forward to this point forward, things reopening in Ireland, I just wanted to highlight that. Just the importance of fresh air, ventilation, all just mitigation measures against airborne transmission. It's going to be really important as things start opening up. The next slide, please, Ben, and final slide. I just wanted to we haven't done an international context for a few weeks, and just to say that until recently, cases and deaths were rising in the European Union, and thankfully that's turned. And this chart is also a linear scale, 7-day average of COVID cases per million people. And so, say in the context of Ireland, we're seeing the UK has been good for the last few weeks in terms of case numbers compared to where they were, and the European Union has kind of vaccination program, multiple things going on. There was lockdown in France, but the case numbers have been coming down around Europe. So that's the local context, and that's the end of the situation update for this week. So thanks.
James, thank you very much for that succinct but very comprehensive update. Of course, it's very gratifying to see the falls in incidence and mortality in the elderly in response to the vaccine. But it's clear that the virus is still circulating in our community, and there's a need for continued vigilance to protect our younger and as yet unvaccinated middle-aged adults from COVID and of course the risk of long COVID, which remains is significant concern, particularly over the next few weeks as we begin to open up the economy. Now I'm going to ask Dr. Douglas Hamilton to speak. Douglas, as I've said, is a public health physician and medical officer of health with the Midlands HSE, and in a previous life, Douglas has worked as a surgeon and in global health. So Douglas, you're very welcome, and we look forward to your talk.
Garmahagat, Ivan Garmahagwiv Goler, thank you for attending. Good afternoon. So as Ivan says, I'm a specialist in public health medicine. So I work on the ground in the Department of Public Health, and this talk comes with that experience and from that perspective. So the name of the talk is Refocus on the Regional Department of Public Health for Pandemic Control. Next slide, please. Can I have the next? Thank you. Okay, so, well, I think it's fair to Ireland was clearly unprepared for COVID-19 with a long legacy of chronic underinvestment in national and regional public health functions. But Ireland has performed well in many areas of the pandemic response so far. And although our lack of preparedness meant that we were reactive rather than proactive much of the time, I think we can pride ourselves on some extraordinary achievements, albeit at a massive cost. For example, flexible and innovative testing services were scaled up quickly. In terms of communication, information from the HSE was rapidly developed, accessible and available. And I think communication from the CMO was frequent, consistent. Despite limited capacity, public health guidance for priority sectors was developed rapidly. The contact management program, although recognized, I think, as a rather blunt instrument, managed to undertake basic contact tracing, even when the numbers were absolutely overwhelming. The tireless efforts of medical and non-medical staff at regional departments of public health, providing a 24/7 service right from the first wave of the pandemic, resulted in the skilled management of outbreaks across multiple complex settings. Now, this was remarkable given the lack of any IT systems to support such outbreak management. The leveraging of local partnerships by regional departments of public health was key to developing an infrastructure with at least a sporting chance to fight this pandemic. Community health organizations developed rapid response teams which were crucial in supporting nursing homes during the second and third waves. So on the flip side, this led to the creation of parallel structures with varying degrees of integration with other functions. For example, the CMP created fragmentation of contact tracing and was not fully integrated with our national surveillance systems either, nor the regional departments of public health. Finally, and most crucially, we relied heavily on public compliance with public health guidance, and thankfully, the Irish people did not let us down. However, we cannot continue, I think, to rely on this stoic resilience and incredible compliance shown by the Irish people over the past year, because it has come at an enormous cost, the full extent of which we will not see for, I think, many years to come. Next slide, please. So what is good public health? I suppose from my perspective, in a nutshell, it firmly integrates the domains of public health improvement, health service improvement, and health protection, the three domains of public health, essentially, to generate optimal population health. And that's the sort of the bullseye in the middle of this slide, optimal population health. Health protection, for those that don't know, encompasses protection of the community against both infectious disease as well as other environmental threats such as radiation or pollution. Next slide, please. Okay, so our public health coronavirus control goals could therefore be considered in terms of the broader goal of opening up society and the economy safely and therefore improving population health and well-being, and then the specific health protection goal of controlling the spread of infection. And these need to be complementary to each other and be appropriately balanced against each other. I would like to concentrate on two key elements to make us in public health fit for purpose in our bid to control the pandemic and keep society safe. First, we need strong IT infrastructure, including integrated health information systems that incorporate health service and primary care data, including an integrated approach to surveillance data that is readily accessible and available across all levels. And most specifically, we need an outbreak management system. And secondly, and probably more importantly, I think we need strong and resourced local multidisciplinary public health teams led by consultants in public health medicine that can respond rapidly to outbreaks and clusters and integrate actions across the three domains of public health in doing so. This, of course, in turn, then needs to be supported by well-resourced and integrated national public health functions. Next slide, please. So partnership across the HSE and the private health services is absolutely key. Industry, and these require local knowledge, presence, and a building of trust. And that's why the regional focus is so important. The partnerships need to be across the HSE in terms of hospital and community services, with GPs who know their patients on the ground, schools, and we're seeing that at the moment, interagency group, that's the major emergency management model of the An Garda Síochána, the County Council, and ourselves. Industry, we've seen that with meat facts, retail, personal services, sports and exercise, hospitality, etc., etc., etc. And of course, most importantly, the public. We need to partner with the public and engage the public. And as part of the community, engage with the community. And that's why we need a local response. Next slide, please. So we developed very strong partnership approaches right across the public and private sectors, where they needed our expertise and we needed their institutional knowledge of each institution. Before any guidance appeared, we delivered COVID advice packs based on our previously distributed flu packs to all nursing homes in the Midlands. We developed a model of IPC support occupational health support, PPE support, bespoke testing, and a rapid response with all of the nursing homes. We chaired outbreak control teams to ensure the response would be properly coordinated across those nursing homes. In regional hospitals, we chaired outbreak control teams for all outbreaks until we were confident that the capacity had been built within the leading hospital staff that they were able to take over the outbreak management and control. Outbreaks in other public service settings, such as prisons and direct provision centres, etc., required new partnerships and new bespoke approaches. And outbreaks in private sector settings, such as factories, supermarkets, hair and nail salons, etc., 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 all needed their own bespoke outbreak control interventions. GAA settings were notoriously complex because of after-match celebrations, and they tended to spill into schools and continue there. I led multiple tri-agency teams, as I said, aligned to the major emergency response model, consisting of ourselves, the Garda Síochána and the County Council, to address outbreaks amongst vulnerable communities, such as meat factory workers and residents in direct provision centres, where communication gaps, fear and stigmatisation feature strongly. Here we went directly to the sites and supported with information, reassurance and advice in their own languages, followed by Q&A sessions. In relation to travellers, we partnered with SafetyNet to provide pop-up testing and provide health promotion, vaccine advocacy, and infection prevention supplies. Currently, a huge proportion of our work is focused on keeping schools open, and the addition of school inspectors to our team in the Midlands has been absolutely fantastic. The next slide, please. So the key objective in outbreak control is to break the chains of transmission. Each link obviously consists of a source or transmitter, hence the name transmission, from whom the virus exits, passes by mode of transmission to enter a new susceptible host, the receiver. Next slide, please. So this obviously repeats itself as the receiver becomes a transmitter, and with 2 receivers for every transmitter, generating an R number of 2. This looks very easy, neat and tidy, and you see, if you snip one little chain there, you immediately halve the number that are subsequently infected. Next slide, please. But this reflects the reality. This is actually an actual outbreak in a manufacturing facility in the Midlands last autumn. So the Mickey Mouse ears there and the sort of tie are the 3 shifts within this factory. And initially my hope was to contain the outbreak to 1 shift, but it subsequently transpired with testing that specialist staff that worked sort of across the whole factory propagated spread across the factory. Next slide, please. So, you might ask, how can this be so difficult to manage? Why do you need an outbreak management system? Well, this slide here shows inside the red oval what you start with. Surveillance alerts you of a case that we call the index case. Using an exposure risk assessment or a public health risk assessment for each encounter the case has had over 12 days, i.e. from 2 days before the onset of symptoms to potentially 10 days after the onset of symptoms, you identify the risk of being a case in each of the contacts. And there are about 10 risk variables. James mentioned ventilation earlier, but there are about 10 risk variables that we have to consider for each contact, each generating different magnitudes of risk, which therefore need to be weighted in your final assessment. Next slide, please. So, because our risk assessment, the public health risk assessment, is applied when things get complicated, I've developed, with the help of my colleagues, a few public health risk assessment tools, and this is something that's not official in any way, but just maybe give some insight into the sort of work that I might be doing in complex situations. So it's an example of a composite risk assessment tool that I have used a couple of times. This particular one's in a school. The 9 variables in this score in this tool are scored between 0 and 2 and are weighted between 2 and 7. And then you tot up the scores. You can see it gets quite complicated. So often we would just look at the more important risk factors and make a binary decision as to whether contact is a close contact or not. But this is useful for getting a more nuanced assessment of risk. Next slide, please. So similarly, for source investigation, you would look back to all events 14 days before the onset of symptoms in the case, but normally concentrating on encounters between 3 and 7 days back, with the best point estimate at around 5 days. And looking at all those events, you assess the probability of each of these events being the actual source. Next slide, please. So my experience is that source investigation can have 2 key benefits. First, in any setting, like a hospital or a direct provision center or a factory or whatever, I want to know whether the index case acquired infection inside that setting or not, for obvious reasons that it determines whether there's an outbreak or not in the setting, as well as coming with likely serious consequences like propagation of spread already at the stage of identifying the index, with multiple serious consequences following that, and health protection interventions that would be required, including possibly closing off the services, the factory, or maybe the shift or whatever. Now, the key question here is often whether any household member or close friend has had COVID recently, or has had symptoms recently, in which case you would test that person. Secondly, source investigation might identify an amplification or mass spreader event, maybe a christening or a funeral or some sort of family event. And we would take action ranging from information and guidance to all of the attendees at that event, often via the host, to interviewing and offering testing to all those we identify and ask them to restrict movements, etc., all in an attempt to control spread. Okay, so just to finish then, on to summarize my talk, and in terms of where do we go from here, I think from a regional department perspective, we need 2 things most urgently. One is to address long-standing and critical IT infrastructure gaps, including and especially a case and outbreak information on management system. Secondly, we need to strengthen the capacities of regional Department of Public Health to allow for rapid identification, followed by elimination of outbreaks and clusters. This will be key to supporting the gradual safe return to normality. Thanks to ISAG and the committee for allowing me to speak. And I'd also like to thank the incredibly hardworking team that we have in the Midlands. And thank you all for listening.
Douglas, thank you for a really excellent presentation, which captures some of the fine-grained detail and the sheer complexity of responding to COVID at a local level. In much of the debate over the past year on contact tracing, there's been this sense that all that was needed was to set up a call center and employ hundreds of people to answer the phone. And so I think this fine-grained local work, the need for local partnership, local understanding, that they need to go in and develop bespoke interventions in the different sites, the schools, the hairdressing salons, the GA clubs, that's been largely missing from the public debate and public understanding. It's been invisible, and unfortunately what is invisible tends not to be funded and resourced. So I think it's really important that people like you who've been doing such excellent work over the past year, that you don't hide your light under a bushel. And we're going to come now to Anthony's presentation, but we've had one Q&A from Marissa Fagan, who's asked if you have any thoughts on the updated healthy Ireland strategy, which was launched yesterday. Has the plan missed an opportunity to bolster public health services? I suspect it has, and I doubt if it has addressed some of the kind of IT and the multidisciplinary team issues that you mentioned. But I maybe just could give you a chance to comment briefly on that, Douglas. Or perhaps you. Oh, okay, well that's fine. So perhaps.
I'm sorry, I haven't seen that final release, but it's. I was to do my. Sorry.
No. And so that's fine. That's fine, Douglas. In fact, I should have and
can you hear me now?
And yeah. So Douglas, that's absolutely fine. I'll give you some time to catch your breath.
Okay. I just haven't read that in detail yet.
Yeah. Great. So I'm now going to I'm going to call on Professor Anthony Staines, and Anthony needs no introduction. His name recognition is probably at Luke O'Neill levels at this stage. So Anthony, we look forward to your thoughts.
I don't think I'm in quite that stratospheric category of fame. I'll be very brief. We can now see a little over a year into a global pandemic where the management of pandemic has worked and where it has not worked. And very largely, it has not worked in Europe. It has been pretty bad in the United States and has been a catastrophic disaster in Brazil and India. It has worked really well in New Zealand, in Australia, in China, in Taiwan, in South Korea. It's worked very well in Iceland. It's worked well, not quite as well, but pretty well in Finland. It's worked in parts of Canada and not in other parts. And it's maybe time to put together what's the common thread in the places where this has been done successfully. Right at the beginning of this whole episode, Mike Ryan did an interview, and he said something that stuck with me ever since. He said that in pandemic response, and Mike has forgotten more about pandemic response than I know, but in pandemic response, the perfect is the enemy of the good. You must act. You must act quickly. You must get ahead of the virus. The story of our response in this country and in many other European countries has been tagging behind the virus, waiting to see what the virus will do next, and then responding to it. And that has prevented catastrophe. It has, because of the extraordinary patience of our populations, it has kept the virus in check. But countries that have done better than that, countries that have really controlled the virus, have all had one thing in common. These countries have different geographical spaces. Some are islands, some are not. Most are democracies, some are authoritarian states. Some are relatively economically isolated countries. Others are completely integrated into global supply and travel chains. Some of them tourism matters a lot. Some of them tourism is a rounding error in their gross domestic product. But what they've all had in common is an active, aggressive, public health-led response, supported by many other things. This is not something public health delivers on its own. But for example, in South Korea, they set up a series of epidemiology teams who reported to the regional public health departments. And they set up several thousand of these. I think they had 5,000 people employed. Now, Korea is bigger, much bigger than Ireland. And these teams' sole job was to do what Douglas has just described, to identify cases, do source investigation to find out where the cases were coming from, and to support people, to do contact tracing to see who they might be spreading to, and to support people in going into isolation so they didn't spread further. At the same time, in this country, when this was suggested to NEFIT, Professor Nolan's comment was that retrospective contact tracing, which we would call source investigation, was of academic interest only, which I think puts us in our place. In New Zealand, more or less by accident, they started out as we did. They were caught completely on the hop. They didn't expect this at all. They started out doing contact tracing with pencil and paper, graduated to spreadsheets, and swiftly built an IT system, a bit like the one we have, but with the crucial difference that their IT system was regionally based. And they then developed it over the subsequent year. And they now have a very slick system which ties up testing, interviews with potential contacts, source investigation, hotel quarantine, and so on. So everything is in one place. So they started pretty much where we did, but they didn't stop. Australia, for the first time in living memory, closed the borders between Australian states. The Northern Ireland border is like a fortified wall compared with the border between the Australian states. Most Australians barely know where the state borders are because they haven't been relevant for anything for over 100 years. But they managed to control movement across the state borders in a way that was reasonable and fair, because as is the case in Ireland, and is the case in many other countries, a lot of people live close to the borders and cross the borders daily for work. So those people need to be dealt with differently, and they were. In Atlantic Canada, which is essentially a number of small areas of fairly low population, but with strong public health units, they control the borders. They started aggressive track, trace, and isolate. Because they're small areas and everybody knows everybody else, the personal connections and personal contacts worked well to identify what was going on. Something very similar happened in Iceland. Finland, which is an incredibly spread out country, which is mostly water, it's mostly lakes, also has a very strong local public health function at municipality level and a very strong intelligence-driven central public health function in a thing called THL. And these have worked together for, I don't know, 40 or 50 years, certainly to my knowledge. And they continued working together. They worked together actively. The local public health departments had full access to information from other departments. They had full access to the laboratories. They had full access to passenger manifests. They had full access to what was going on in their country. And that enabled them to control the spread of infection within Finland in detail. And the hardest place to deal with, as you would expect, was Helsinki. So I think the moral of this story is that while Ireland has not done nearly as badly as we might have done, and there are many things that we've done well, our vaccine rollout, for example, has been excellent. Nonetheless, all the costs of managing this pandemic have been placed on the shoulders of the Irish people. We've had an extraordinarily long lockdown. Something else WHO said in March of last year was that lockdowns were not an appropriate tool to control infection, that the purpose of lockdowns was to bring numbers down to a point where you got out of trouble with your health service being flooded, because we'd all been sitting in Ireland watching what was going on in northern Italy, and we did not want to see that happening here. But it also gets cases down to a level at which you can actually do the sort of detailed, meticulous contact tracing that Douglas and his colleagues are talking about. And that can be very effective. So I think something we do need to learn from all of this is, because this is undoubtedly not the last pandemic we will see. We need to learn to mobilize public health early, to mobilize it in a way that is integrated, and to give it the resources that is required to do its job. And during a pandemic, those resources increase hugely, but temporarily. And certainly for perhaps 40 or 50 million, which is less than we spend a week on pandemic preparation at the moment, we could have had a remarkably slick test, trace, and isolate program, and we would now be in a position to open up and have a very ordinary summer without any great concerns. As it is, we are having a race between the virus and vaccination, and we all hope the vaccination will win. Thank you.
Thank you, Anthony, for that. I think it's for that excellent overview. It's a very helpful international perspective that complements what Douglas has just said. And I think what you're saying is that in the countries that have done well, there's been a strong central public health infrastructure, but the resources have been poured in at local level in terms of the fine-grained, granular work that's required to respond. And this idea that, as we know, a pandemic is essentially a series of local outbreaks, and it needs to be responded to at local level, but with support from the centre. And of course, we've heard so much about Ireland's lack of hospital beds, and the fact that we have fewer ICU beds than the rest of Europe, and that's why we've had such a long lockdown. And of course, that is true, and no one doubts the importance of that. But the other reason, as you have highlighted, we've had such a long lockdown, is that we've had such a rudimentary public health infrastructure, that has been neglected to an almost calamitous extent over the past two decades. And it just brings you back to I suppose highlighting the outstanding work that our public health colleagues have done, despite the fact that they don't even have a functioning outbreak management system, which you would think would be absolutely fundamental. So we have time now to open the discussion, and I wonder if Gabriel Scally, who's been involved with these issues all of his working life, and would have some, perhaps I'd like to offer a UK perspective.
Thanks very much, Ivan. I think one of the things we've learned is that the importance of our public health infrastructure and making sure that that is in place, because we don't know at any time what is going to be coming at us. And this surely will not be the last major public health challenge we face. We were well warned internationally and at national levels about the importance of getting an infrastructure right. And it does seem quite amazing. I think it will not be looked at very favorably that we didn't even have an IT system capable of handling major outbreak on the sort of scale that we've had, yet alone something globally and with the international ramifications that have been mentioned. So, and it is really, really important that we take the opportunity of look at how things have gone. Interestingly, Boris Johnson today has announced that there will be a public inquiry. He's announced it will commence next spring in the UK. I assume it will cover the whole of the UK, but it may not. We may end up with 4 different inquiries, and we probably, for the UK, do need 4 different inquiries to look at, because the infrastructure is quite different in different places. For example, Northern Ireland is the only part of the UK that doesn't have local directors of public health, like the Republic of Ireland, like Scotland, like Wales, like England. They were abolished in well over 10 years ago now. And infrastructure is different, and the response has been different in different parts of the UK. So there's no one place that has got it right. Some things have been got right in different parts of these islands, and we need to have that learning. I do think that an inquiry is the right way to do that. It depends, of course, on the terms of reference of the inquiry. I very much hope that whatever inquiries are established, that there are practicing public health people part of that inquiry team. That's absolutely vital wherever that should happen. And one of the things I think we've got to think about, and one of the good things I think about the that has happened in the Republic of Ireland during the course of this COVID, is the fairly recent announcement about the consultant status being finally agreed for the doctors in public health medicine, and also really significant numbers of appointments to be made over the next year or two. So that's a really major step forward. But it does need to be part of a whole organized public health system. The sort of efforts that have been made at a local level in the Republic of Ireland are absolutely tremendous, and they're only possible because there was some staffing there across the regions. But we can't have a staffing that is only set up and tasked to deal with major infectious diseases outbreaks. We need a staff that is flexible, that will be able to be repositioned to deal with communicable disease or environmental hazard problems when they occur, and we needed part of an integrated public health system. And one of the things that I think is extraordinarily important is the role of communities. And for public health to operate effectively, it has to be locally based. It has to be well connected with communities, with councils, with county councils or city or town councils, whatever is in place. And the public health leaders have to be highly visible, well known and well respected, and given a place in those systems so that they can always be able to bring public health concerns to attention, and that they can command the respect of the public, the respect of public officials and elected officials, and command the resources that they need to do their job when they need it. Thanks very much, Adam.
Thank you, Gabriel, for those interesting comments. It is interesting to hear that Britain is planning to hold a public inquiry into the response to COVID. The UK tends to do public inquiries fairly well, and hopefully we can all learn from that, as we've learned from previous high-profile public inquiries in the national service. And as you say, it's to be hoped that it will be set up, and that people like yourself and other public health practitioners and scientists get an opportunity to contribute to that. So we have time now for some discussion. In fact, there's a question as to whether we need an inquiry into the pandemic response in Ireland. A question again from Marissa Fagan. Personally, I would think that would be money well spent, although we do tend to be rather more legalistic and protracted in our approach to public inquiries. They tend to take a long time and cost a lot of money, because everybody needs to have barristers and multiple layers of legal defence. But if we could get around that, I would have thought that a public inquiry in Ireland would also be well justified. But I would welcome people's comments on that.
Well, Ivan, if I could comment on that first off, I have some experience of these matters, as most people know. And my view is there are times when a public inquiry, judicially led, is required. And it is required if there is any sense of obstruction on behalf of either bureaucracies or individuals. It is required when those powers are needed to command witnesses. It is required when it is going to reach judgments in regard to the actions of individuals. I don't personally feel that that is the territory we are in, particularly, and I don't think it would be helpful to go there, because a lot of my experience of dealing with these matters, there is a temptation to look for scapegoats in inquiries rather than look for the systemic problems, and a reluctance sometimes to deal with those big issues and the big changes that are needed. So I don't think a full tribunal or public inquiry is needed in the Republic of Ireland. I would like to think that it could be a minister appointed inquiry or a cabinet appointed inquiry with a relatively short time span and with a very clear set of terms of reference. And we've got to remember, although we may be hopefully getting through the COVID pandemic now, another one could come along, not in 100 years' time again, and not in 10 years' time again, not in a year's time. It could come at any time. So there is no time to be lost, in a sense, in terms of getting things right for the future. So I do think an inquiry of some form should be initiated. And I think there is also a necessity for that to have an all-island approach in terms of looking at the all-island issues that haven't been satisfactorily addressed. I think the inquiry would have to look at the issue of the operation of the Memorandum of Understanding and how that has operated. Has it been effective or not? And in order to do that, I think a degree of participation across the whole island would be very helpful. Thanks, Alan.
Thank you. So really what you're saying is that a well-focused inquiry that would be forward-looking and focus on systemic issues is what we need. Thank you. So I just wanted to come back, I think, to Douglas. I want to come back to Douglas, if I may. And we've had there's a good bit of controversy in recent weeks about the place of antigen testing. I don't know if you would I'd be interested to hear your thoughts on that from your experience on the ground.
Yeah, thank you, Ivan. Well, look, I think all tools that can in any way give us a better understanding and a better identification, in this case, of cases and of transmission is welcome. I think antigen testing can provide that. It is cheaper, you get quicker results, you can have them self-administered. I think the problem is now that we don't have proper either clinical governance or testing governance with these antigen tests that are sold in Lidl, for example. So it's up to the people themselves. I'm all for community engagement, but I don't think it's right for the people themselves to make clinical decisions and testing decisions. And I think we're all caught a little bit on the hop. So I think this could be trouble, but I do think that we need to go with it, and we do now need to really tackle and use antigen testing for case and cluster identification and outbreak control.
Thank you, Douglas. I think, as you say, the debate has been, people have been to some extent at cross purposes, with some contributors focusing on the performance of the tests, and others trying to address the setting and context in which the actual tests are carried out. So I think there's the, you know, it's a complex issue, and certainly I would share the reservations about the tests at Little that we've been hearing about in the past week. Is there anybody else would like to comment on that? Perhaps Jerry Killeen, if Jerry's hand up.
Sure, I'd just say briefly from experience, I think one of the problems here with COVID specifically is that the virus dynamics are very dynamic. You know, you can go from being having no detectable parasitemia viremia even by PCR to being fully infectious, you know, within 24 hours. So it's just a difficult thing to do in practice. I think it's really a job for, and the frequency you need to do it is therefore very high. It's like daily testing, and that's really not a job for households. So I certainly agree with Douglas that it's time for the specialists, you know, the experts in the field to really take a grip on the agenda and start driving forward sensible applications of these technologies, which we do use extensively in other parts of the world for other diseases.
Yeah. Thank you. Anybody else want to comment on that before we move on? Any other? I suppose the other issue that I suppose we're a little bit, that's in the back of our minds and in the context of local outbreak, is the concern, the real concern that we will have a fourth wave in response to the opening up that has now commenced, and you know, do people are we moving too quickly? Anthony, would you like maybe to?
Yes, I'll respond to that. I think we are running a risk. We know from other analyses in other countries that there are a number of variants of concern out there which appear to spread more effectively than the B117 variant, which is the dominant variant here now. We know that variant was introduced into Ireland probably at the beginning of December, and we were running at several thousand cases a day by the end of December. So we have had this experience already. We are opening up. I think the message has got out to the public that they need to be cautious. And there are things I think we can all do. Wearing masks, remaining outdoors to the extent possible, being conscious that there are risks, turning up for testing, reporting symptoms, all of this will be very beneficial. We still don't have a working local public health function capable of controlling aggressively small outbreaks because there are too many cases. If we can bring the case numbers down, I think we can probably prevent the outbreak of any new variants completely. And we can open up with much more confidence. If we had 50 cases a day instead of 400 cases a day, everyone would be much happier about doing whatever we're doing. Many of us, myself included, would be much, much happier if we had no cases a day or single digits of cases a day, providing we have the public health mechanisms in place to keep that state of affairs. And as we vaccinate, because the vaccinations seem to be very effective, they're not perfect. They're not the solution to all our problems, but they have a huge contribution to make. And as we vaccinate over the course of the summer, things will become easier to control. But right now, as NEFIT have said repeatedly, we are on a knife edge and we don't know which way we're going to fall off the knife edge. We could fall in the good way and start case numbers falling down very rapidly, or we could fall in the bad way and have another wave. And that's one of the things that's been suggested as a distinct possibility by an effort themselves. And hopefully it will not happen. But I think that's where we are. We're taking a calculated risk.
Yeah. Thanks, Anthony. I think that's a good summary. Calculated risk, and we need to be vigilant. As we come to the end, there's been some response on the Q&A to the suggestion that we have an inquiry into the pandemic response, and there's a support for a well-focused, forward-looking inquiry. There's also a question from Una Smith, who'd like to put a question, but I don't know if Una can put it live, but she's a question on contact tracing and data, the data that's been nationally collected on contact tracing. I don't know if anybody would like to comment on that. I did see my colleague Patricia Carney on the call. I don't know if Patricia, I know Patricia's doing some work at national level on this. I know that the HPPSC are currently collating the data from the CMS system, the contact management system, on contact tracing, which will give us some insights into the overall performance of the system. And I think that even though the system, as we've had, as we know, has been far from perfect, I think that there will be important lessons to be learned from a detailed interrogation of the data that has been collected. So as we come to 1 o'clock, I think we should wrap up. I think we've had a very interesting and I believe useful discussion on the vital work that our regional public health departments have been carrying out over the past year to control the pandemic. And of course, we're far from out of the woods yet, and we need to be ready and waiting for the next pandemic. And of course, when the pandemic does recede, we will have the other public health problems and challenges, including the climate emergency, the ongoing issues of alcohol and substance misuse, and the obesity pandemic in children and adults, etc. These problems will still be there waiting for us. So I think it really highlights the need now to consolidate and invest in our public health departments. It is, of course, tremendous that we now will shortly have public health consultants, but we need to give those consultants the support in terms of the multidisciplinary public health team, the epidemiologists, the surveillance scientists, the public health nurses, and the health promotion specialists, and so on. So there's a lot of work to be done in this space. So we'll wrap it up there. And again, I'd like to thank Douglas and Anthony and James for their presentations, and we look forward to seeing you at our ISAG press conference next week, which will be focused on the absolutely critical issue of global vaccine equity. Thank you, everybody.